So good afternoon, everybody. It's 1 o'clock. I'm sure some more people will be joining us as we go on, but we've got a lot to cover, so we will get started. I hope everyone can hear me okay. I've had a few internet issues today, so apologies in advance if anything goes wrong. But yes, a very warm welcome to this webinar on FIT. My name is Cat Hodges. I am the primary care lead for the Surrey and Sussex Cancer Alliance, Surrey based, and my counterpart in Sussex, Jo Thomson, is on the call as well and helping with the chat. We are really lucky to be joined today by some guest speakers who are experts in the field of FIT. So we have Sally Benton, who's a consultant biochemist at BSPS and is director of the NHS Bowel Cancer Screening Programme Hub. We have Phil Bearn, who's a consultant colorectal surgeon at Ashford and St Peters, and Neil Cripps, who's a consultant colorectal surgeon at University Hospital Sussex NHS Foundation Trust. So we are looking forward to hearing from everybody to help demystify some of the information that's surrounding FIT. So this is our agenda for the day. So we will have go through the guidance, what's the difference, repeating FIT, the new Surrey and Sussex Cancer Alliance referral form and the accompanying guidance with that. And then I'll cover off some issues around safety netting, the changes to the IAF and some of the resources that we have in primary care. Just a little bit of housekeeping. So this webinar is being recorded and we will circulate all of the slides afterwards. Keep cameras off and microphone on mute unless you are a speaker, and please do use the chat box. We're really keen to get everyone's questions in there, and if there are things that we don't manage to answer today, then these will be looked at and circulated in a follow-up. We had a similar webinar in Sussex last week and we've got some questions from them, so we will be combining just to kind of make sure that we've got a really useful document for primary care that answers everything that you need to. We've also got a feedback survey, so please do fill that in. We're really keen to make sure that we're keeping these webinars relevant for primary care and understanding what people want going forwards as well. So just a little bit of introduction as to why we're all here today discussing FIT. So in 2022, the BSG, the British Society of Gastroenterology, with partnership of the Association of Coloproctology, issued some guidance about the use of FIT testing in primary care, recommending it for use in patients presenting with all NG12 suspected colorectal cancer symptoms. And the exception to that is those with an anal rectal mass or anal ulceration. And this guidance has now been NICE accredited, and it is being looked at to be incorporated into formal NICE guidance at the end of the summer. It's also really important from a primary care perspective, from a funding point of view. So there's been an update to the investment and impact funding target. So 65 to 80% of urgent suspected cancer referrals need to be accompanied with a FIT test result within 21 days before the referral. And I'll be talking about some of the tools that we've got to help us to ensure that we can manage to meet that target. So that's a little bit of scene setting. I'm going to hand over to the experts in the field to talk you through kind of where this guidance has come from and, as I say, kind of demystify a lot of it for us. So thank you very much, Sally, for joining us today. I will hand over to you.
Cat, sorry, I'm just trying to pop out my screen so I can see it bigger. There we are. Okay, can everyone see my slide? The slide?
Yeah.
Yes. Okay, so I've been asked to talk about just give a bit of an introduction and a bit of a background to FIT. So as I'm sure everyone's aware, FIT is positive, or fecal hemoglobin concentration is positively associated with disease severity. So we know that people with a cancer are likely to have higher concentrations of fecal hemoglobin, and likewise people with no serious bowel disease are more likely to have undetectable fecal hemoglobin, but it is a surrogate marker, and so we do know that there's overlap. So some people with a cancer will have undetectable FIT and fecal hemoglobin, and there will be people that have no pathology seen on colonoscopy that have detectable hemoglobin. So it's by no means a perfect test. So historically, we measured fecal hemoglobin using the Guaiac fecal occult blood test, and this was a very crude method that I'm sure lots of you are familiar with. And we basically looked for a blue colour when we added hydrogen peroxide to the sample. It wasn't specific for human hemoglobin and was incredibly subjective and qualitative. So we have since more recently moved to the Faecal Immunochemical Test for hemoglobin. Now, FIT utilises the fact that the polypeptide component of the hemoglobin molecule is species specific. Antibodies are derived that bind specifically to the human globin component. We can give patients a tube, as again, I'm sure you're all familiar with. The tubes look different from the different manufacturers, and the patients swipe this, the probe into their stool sample, pop it back into the tube that contains a stabilizing buffer, send it to the lab, and we can analyze it on a system similar to these. So the system that we use in the bowel cancer screening programme across the whole of England is the OC sensor Plesia, as you can see here. We also use that for our symptomatic population in the Berkshire and Surrey Pathology Service Network, so in Surrey. And the HM-JAC is the other most commonly used one across England, and I believe parts of Sussex, their lab use this analyzer. So I got asked to just briefly talk about analytical thresholds. So typically in a lab, any analyte we measure, we report down to the up to the upper limit of the measurement range, which is around 200 for FIT. To go any higher, we'd have to dilute the sample. And then the limit of detection is at the very bottom end here. You can see 2, and that's the lowest concentration that you could confidently say there is some hemoglobin present, or there is some of that analyte present. But you're not confidently able to measure it at the limit of detection. So the limit of quantification is the lowest concentration that you can reliably measure. So you can confidently say the amount of the analyte that is present in the solution. So for fecal hemoglobin, for our method, oh, can everyone see the slides?
No, it doesn't appear that everybody can see the slides.
Okay.
Oh, sorry, everybody.
I'll stop sharing. Oh, some people can.
For anyone who can't see the slides, maybe try just leaving Teams and coming back in again.
What
I think it's a mix, Sally.
Could those that couldn't see them when you were speaking, Cat, I wonder?
Shall we carry on, and those who can't see just try and drop in and out again? I think some people can, Sally.
Okay. Do you want me to? Oh dear, I've just changed the layout back. So do you want me to keep going?
Yes, please.
Okay. So we talk about the limit of quantification. So for the BSPS, we report down to 6 micrograms per gram, which is our limit of quantification. Other labs have chosen either to report to the limit of quantification or just down to 10. But just to explain to everyone, that's why we are reporting down to 6. which is below the NICE and BSG and the referral threshold of 10. So the so we can report numerical values between the LOQ and the upper limit of the measurement range, which we do. The NICE and the BSG now have support the evidence that's come out of the BSG review supports the 10 microgram per gram threshold for referral in a symptomatic patient. And this is for whatever method is being used. But just to highlight that the screening threshold in England is 120 micrograms per gram, which is a lot higher. This in the screening, as I've said, uses the same as some of the symptomatic fit kits. They look exactly the same and they are analysed in the same way, but the way the results are reported, the threshold is hugely higher, so 12 times higher for screening. And this isn't a choice based on, it's not a clinical decision, it's a practical decision based on the colonoscopy capacity that's available in the system. So we do know that the screening programme is going to miss huge numbers, potentially, of cancers and precancerous lesions. So it's just to highlight to you as GPs that if you get a patient that's come in and said they've done their screening fit and it's negative, I would urge you to either repeat the fit with a symptomatic sample or to ask your patient to contact the screening hub and they can ask for the actual value of their haemoglobin, of their fit result. So we will then send them the fecal haemoglobin concentration. So as I've said, if the patient presents symptomatically, it's important to request a symptomatic fit kit. So I'll now hand over to Phil and Neil to talk about the fit guidance that's come out.
Yeah, hi there. Can you hear me, Sally?
Yeah, I can.
Okay, right.
Hopefully everyone else can.
Great, it worked. So I think I'm not going to. There we go. So just some really boring stuff, the sort of thing that we look at and forget pretty quickly. But obviously the ideal test has high sensitivity, high specificity. And for these tests, you want it's got to be positive. It's not got to miss much. And if it's negative, it's not got to miss much either. So basically, you want high positive predictive value and high negative predictive values. And the fit does seem to fit the bill on this in this case. So for all cancers which are referred on the urgent pathway, there's a threshold which is set, which is that must be more than 3%. So I guess how does this apply to colorectal cancer patients? Well, if you look at symptoms, their positive predictive value is pretty low. If you just have diarrhea, positive patients low. Change in bowel habit a little bit more, and if they are anemic, a little bit more. But you also have to remember when you're being good doctors and taking your history, that it's important, as we'll see later, that you treat these patients sensibly. So if you're a 20-year-old with painful anal bleeding, it's probably the urgent care pathway with a positive fit is probably not the pathway to refer them. And in addition, looking at other pitfalls, patients diabetics have pancreatic exocrine insufficiency, which may or have had a gallbladder removed. It's just trying to think slightly out of the box on these symptoms. But I appreciate that's not always easy with 8 minutes consultation, and we have the luxury of a bit longer in clinic. So what are if you combine symptoms, then the risk goes up a little bit more. And if you have a positive fit, you can see on the top right that you really have a good chance of that patient having a cancer. So this was a very important study on which many of the guidelines subsequently have developed and further studies, and Neil's going to go through his personal data shortly. But this is a paper published with the lead author, De Souza, and this is a multi-centre study which originated in Croydon with the lead author Muti Abalafi across many hospitals. This particularly tried to look at how the FIT test fitted in with the patients on the urgent care pathway, and to see whether it was possible to work out a threshold by which you could actually use the test and use that as a discriminator as to whether you investigated these patients further. So if you remember, if you look in the threshold of 10, which is the one that we're operating on, at that level has a high sensitivity, it has a high specificity and good predictive value compared with the previous symptom related ones which you've seen earlier, and good negative predictive value. So this, of course, if you raise the FIT to a higher level, then you've got an increase. You will of course get an increased yield of cancers. But 10 seemed to be the one that was best suited to the clinical situation. So, but we have to accept that no test is absolutely perfect. Ovarian cancers and lung cancers are missed by their standard tests, as are prostate cancers. But fewer colorectal cancers seem to be missed by this test. Put it another way, and this goes back to the De Souza study. If you're looking at the patients that will have bowel cancer and who had a negative test, they are just the 3 red ones in the middle of this picture. So I think one is pretty reassured that this is a proven and effective test. Neil.
Okay, so I think that the key part of all this FIT work is actually one of reassurance, and the main issue that we've got is everybody has a fear of missing bowel cancers. Now, these data, which pretty much are, albeit from last year now, I can update these at any time, and it shows us the same figure, that if we do FIT tests on patients that are referred under the Cripps 2-week rule, you can see that we have something of the order of 5,500 people with a FIT test, and in fact there are more people than that, 6,000 or so, who get referred. We can see that the real life data actually bears out the trial data, which was undertaken in that multi-centre study. And what we can see from the University Hospital Sussex data is that if you actually do have a FIT below 10, then your bowel cancer risk is 1 in 200. And that should be hugely reassuring to the vast majority of people, unless they've got symptoms that are of concern. And it's interesting to note, and Sally's been talking a little bit about FIT thresholds here, that even if your FIT is between 10 and 100, then the bowel cancer risk is below that of the NG12 threshold, which is, as you know, 3%. And whilst the total FIT cancer conversion, if you will, in all of FIT referrals is 3.8%, which is a little more than the NG12 threshold, the real palpable risk of cancer comes when your FIT is more than 100. Now, that's relevant because whilst we are accepting referrals between 10 and 100, we know that the FIT threshold is likely to change in the future, because we're still examining a lot of people who are potentially harmed by having unnecessary investigations. And if we think about the potential for FIT, it's best summarised into these 4 boxes. And I think the key point is that what we're trying to do with this fit triage is to get patients to access the correct pathway at the right time. And we know that if your fit is less than 10, then, and you've got significant symptoms, because we wouldn't be referring, or you wouldn't be referring patients to an urgent cancer, suspicion of cancer pathway, unless there was a concern. And the point is that if your fit is less than 10, then you're probably something like 9 or 10 times more likely to have a cancer outside of the GI tract. So referring somebody onto a colorectal two-week pathway is probably not in their immediate best interest, and there may be other investigations which would suit them more immediately. And the sort of the flip side to that argument is that by taking people off the colonoscopy pathway at a lower fit, if we get to investigate people with higher fits more urgently, then that similarly allows them to access the pathway, the right pathway for them more urgently. The other side of that coin is that if we've got people in whom we are not particularly concerned about their symptomatology, and they might be in the sort of what we used to know as the DG12 cohort, which is the low risk but not no risk cohort, then having in the knowledge that your bowel cancer risk is really low and you're really unlikely to have to be missing a cancer is hugely reassuring. And we're moving into an era now when we're trying to temporize people with symptoms to see if they'll settle, because the vast majority of non-significant symptoms will settle with time, which is why we going back to the original two-week rule criteria 20 years ago. We set those windows of time for symptoms to allow them to resolve, and the vast majority of people with, let's say, for an example, a change in bowel habit to a looser stool will settle within 2 to 3 to 4 weeks, which means that when you go back to normal and you've got a low fit, then your risk of cancer is really much lower than the 0.5%. And what we're trying also to do, and it sounds a bit like rationing, but it's actually rationalizing, is that we know that when people get to a relatively older age and with comorbidities, that these difficult investigations can sometimes cause them more harm than good. And we reckon on something of the order of a 1 in 500 chance of significant morbidity or even mortality related to colonoscopy. So that if your risk of bowel cancer is less than that, then you're probably better off not having the test in the first place. So the take-home message from the FIT papers, and these are the BSG guidance, BSG ACB guidance of last year, which suggests that FIT should be used by primary care clinicians to prioritise patients with clinical features of bowel cancer for referral for urgent investigation. I just want to take a slight sidestep to that, and I think the key phrase in here is clinical features of investigation. Now, Sally has already alluded to the fact that we know that the screening threshold, which is putatively for asymptomatic patients, and the symptomatic threshold, which is putatively for people with significant symptoms, we know that they're very different. And what we don't want to do is end up referring people who don't really have important symptoms to colonoscopy because they've got a fit of 10 or 11 or 12, because that would be effectively screening the population, which is going to expose people to unnecessary colonoscopy, and we've already alluded to that morbidity. So I appear to have, oh, here we are. So the take-home message is that FIT is equally effective in high and low risk symptomatic patients for the different reasons, both of reassurance and both for prioritising urgent referral. It's also important to say that we can use FIT in rectal bleeding, and whilst there is an idea that rectal bleeding is always a high risk symptom, as Phil alluded to earlier on, if you've got rectal bleeding with anal symptoms and you've got a normal digital rectal examination, or it demonstrates piles or a cause to that bleeding, then the odds are very likely that that bleeding is coming from anal cause. And so what we're saying is that please use FIT for rectal bleeding. We accept that there'll be more people with a positive fit in the rectal bleeding cohort, but if you have a negative fit in the presence of rectal bleeding, you can still be reassured by that. And we've also said that, or it also said that in the presence of an abdominal anal or rectal mass, fit is not required at the time of referral. Now we hold that to be true, but if that mass is not confirmed on physical examination when the patient is actually seen, then a fit test is very helpful for us to then subsequently triage the patients to the right cohort. So whilst please refer patients with an abdominal rectal or anal mass, if you do make that referral, don't wait for the fit result, but please do a fit at the same time so that we can pick up the fit result when we see the patient. And the final slide is a very simple algorithm which you can easily read yourselves in the subsequent release of slides. Basically, if you've got significant symptoms and the fit is still low, then you should still refer on the 2-week rule pathway if the symptoms meet the urgent referral criteria. But otherwise, there's a very great role for reassurance or referral onto an alternative pathway, depending what the symptoms are. And I think that's my final slide to say that please refer patients with a fit concentration of greater than 10 micrograms per gram on the urgent cancer referral, but emphasising that they do have to have symptoms that could indicate the presence of a bowel cancer. And patients who are symptomatic, significantly so, they should not be excluded from referral on the basis of a fit test alone, because we do know that some of these bowel cancers present with a negative fit, but they have almost universally got important symptoms. So important symptoms and a low fit, please consider whether it's the right pathway, but very definitely make a referral if that's the case. And now on to Sally, or back to Sally. Thank you.
Hi there, thanks Neil. So I'm going to talk about repeat fit testing. And the reason we've decided to just mention this, just touch on this, is that it's a question I get asked quite frequently by GPs as to whether if they do a second fit and it's still negative or it's still positive, does that help in the decision-making process? So are the slides still visible? Yeah. Okay, so so basically there's we don't really know. So I've got a colorectal research fellow doing his MD with me at the moment, and we decided to look at replicate and repeat fit testing, and he carried out a systematic review that I've summarised here, and I just need to pop it out because I can't see these slides, they're so small. And basically, there were only 7 papers that we could include in the systematic review, and the summary, they were basically inconclusive. So there was, at the point of publication in this review, which was 2022, sorry, I've put 2023 on the slide, there was no consensus to support or refute the use of repeat fit. Now, this is something that is being picked up nationally. There's a lot of discussion around it at the moment, and a group up in Preston in the northwest of England looked at a huge cohort of their patients who they asked GPs to carry out 2 fit tests. Now, it was very much done in an observational way in terms of the fact there was no sort of structured study strategy to it, but they did demonstrate that 2 negative fits do increase the so if you have 2 negative fits on a patient, the risk of cancer is lower than the 0.5% that Neil alluded to earlier at the threshold of 10. And in fact, Nick has also looked at some replicate fit that we received during the COVID pandemic on patients referred to the Royal Surrey. And again, sort of conversely, but quite reassuringly, all those with colorectal cancer had a double positive fit. So this isn't conclusive, and we've got a study going on at the Royal Surrey at the moment, and there are a couple of other studies going on around the country. But but the outcome from, and the BSG, we did look at this as part of the BSG ACP guidance, and there was currently insufficient evidence to recommend the use of repeat and second fit to guide referrals in routine practice. So currently the recommendation to GPs is to only do one fit, because if you do two, we're not entirely sure how we would interpret those in combination. And the sorts of questions that we need to consider are: what should the retesting interval be? How many repeats are required? So the study that we're carrying out at the Royal Surrey on patients referred onto the 2-week wait pathway are they're going to be getting 3 fits rather than 2 to see if that adds any value. And we're doing it at a very defined testing interval. And should the thresholds remain the same? So already in terms of symptomatic fit, there's a lot of work being done looking at thresholds on a single fit test, and in Nottingham they have increased their threshold to 20 actually. So there's a lot of work being done around this. So sorry, in summary, no, you shouldn't be doing repeat fit testing. Back to Phil.
Thanks very much, Sally. So the guidance we're just going to give you is hopefully preempts what's going to come out later in the year. And I'll just go through it very briefly, but it takes into account the use of fit in the referral pathway. So I don't think there's any doubt in my mind or any clinician's mind that if you feel a rectal mass, or you look at the anus and there's something sinister that you feel could be an anal cancer, or if you examine their abdomen and there's a great lump there, or indeed if the patient is unable to do a fit test, then we wouldn't say that we would want the fit test result there available when we see the patient. These are such strong symptoms that we would want to see them in our urgent clinics, which we'll go on to in the next couple of slides. But if it's above 10, I think these are not particularly controversial. We've greater than 40 with unexplained weight loss and abdominal pain, so good cardinal symptoms. Neil has touched on rectal bleeding. And unexplained, I think if you're seeing someone again, a 22-year-old with an anal fissure, that is explained. I think that's pretty explained bleeding. If it's bright red on the paper, spots and stings, then, or if they are opening their bowels and the hemorrhoids dropping down and bleeding and they're putting it back in, well, you know, I think they wouldn't count. But unexplained, I think we can all understand. The iron deficiency anemia pathway is being developed by the Alliance. We had a meeting about 6 weeks ago, and are developing a pathway for all anemias. But clearly, if a patient has an iron deficiency anemia, they need investigating. And I think it seems to be that most of these anemias, iron deficiency anemias, are actually coming via this pathway now. We've already no controversy on it. And Neil's always said a persistent change in bowel habit. If someone goes on holiday, has diarrhea, and it goes after 2 weeks, well, you know, that probably isn't. So it probably just was holiday diarrhea. But if it's carrying on, and there may well be other symptoms as well, of course, then those patients need to be referred and would on this pathway. And then there's another combination: abdominal pain, change in bowel habit, weight loss, or iron deficiency anemia, less than 50. So if you're less than 50, you have a few more symptoms, then please do. And I think there's the other thing to say is that you've got clinical concerns. But it'd be quite good on that referral that we actually get the clinical concerns, just in case during the triage that it might be perceived that it might be better off on another pathway. What about the ones below 10? And I think this is the one that's really difficult for people. Although I think we've shown on that big slide of 1,000 patients that it's negative. You're not going to miss many cancers, but you may miss other pathology, of course. You know, if your hospital has a non-specific symptoms pathway, or clinic, then there might be an argument for using this. But I appreciate that those clinics may not exist in all hospitals. So I think, as Neil said on his slide, you know, we wanting this fit pathway to help us to direct the patient to the most appropriate clinician. So on this very busy slide, which we'll obviously let you read at your leisure, there is some pretty helpful guidance if you follow it. But I think the most important thing from your point of view, our point of view, and the patient's point of view, is that the appropriate patient is referred. So if someone has dementia, is frail in a care home and is requiring 24-hour care, it may not be the most appropriate pathway to refer that patient on. Although I do understand, as we all do, that relatives of those patients may well want to know what is going on. But so I do see it. But in terms of pickup rates of cancers and what we can actually do, and whether that person is fit to have any of the studies, as Neil has mentioned, I think is really important to bear in mind. So what happens to your patient when you've referred them on this pathway? Now, what we're trying to do in most hospitals is develop, which is what in our model at Ashford St Peters, a nurse-led triage system. So when your referrals come in, the patients will be talked to, or relatives will be talked to by one of our colleagues, and they will then follow up, followed which is not here. We follow up a pathway of their own so that we can triage them into colonoscopy, CTC, or face-to-face clinic. And the nurses that we've got have rapidly become very slick at running this pathway, and with obviously the mappers keeping an eye on the patients as well, so that they're not lost from the system. So I think FIT really does mean that you can direct these patients to the appropriate clinicians, and and if the FIT is negative, then those my colleagues will then they will refer for a CT scan, and then that patient may well be referred to urology or gynecology. So it is the entree, I think, to this pathway. Thanks very much.
Ian, thank you very much, Phil, Neil and Sally. Please, if you've got questions around that, please do put them in the chat, because while we have our experts with us, then we'll look to address those. So what I wanted to do was just talk a little bit through the kind of practical aspects from a primary care perspective and some of the safety netting tools that we have, because I appreciate, you know, it is a big change within primary care, and you know, we need to be just making sure that we are not losing these patients within the system once we're requesting the FIT, and then ensuring that we're acting on that result. So we've kind of broken it down into some of the steps that we would do within primary care. So obviously you've got that initial GP appointment, and if it's face-to-face, then doing the examination or bringing them in for that at a later date as needed. But obviously deciding that, yes, you know, there are concerning symptoms there for colorectal cancer and you want to request a FIT. And our Ardens have some brilliant resources. I'm not going to kind of go through screenshots of them, but they're all available on the internet, and one of my colleagues, our primary care facilitator, is looking at doing kind of a hints and tips on how to use that, so that will be coming. But there is an Ardens FIT template which you can open and will ensure that you're coding things correctly. So next step is kind of obviously just the details, and we've put here just to make sure that when you're requesting it on ICE, that you're actually putting the clinical details there, so that when they're coming back through in the results section, if you're not filing it yourself, or even if you are, it's a bit of an aid memoir to why that was requested, and just to help kind of focus, you know, what the next follow-up will be, depending on whether that fit result is less than 10. Obviously, if it's greater than 10, then that's an easier pathway to follow. Details, just obviously making sure patient details are up to date. And the next bit is just around labelling of the pot, using the label printer, making sure that the form's enclosed. So I think there are a number that unfortunately aren't labelled correctly still. So just a reminder on that front. Ensuring that we're really communicating with patients about the importance of doing that fit and in a timely manner. So ideally kind of returning it within a couple of days, and just asking them to put the date of the test on there that they do it, because, and that's reason for that is with the IAF target, it will take that date as being the date it was requested if there isn't anything recorded at the time of that being the test being done. And so just to make sure that you're getting the payment for that, you want to be making sure the patient records the date when they do it to give that time frame. Fit coding, really important. Again, there's Arden's template that you can use for that, and then you can set up auto codes within your IT system to ensure that that is recorded. We are getting the lower GI bloods section on the ICE profiles, which is in development now, but just to make sure that, you know, it's easier to know which bloods to request for that referral as well. A really useful safety netting tool, you've got your Fit AccuRx, which I'll share in a minute, to remind patients to return that Fit kit. But obviously just explaining to them, you know, why you're doing the test and how they are going to expect to get the results, and making sure that, you know, even if it's a normal result, that they will need to be followed up if they've got those concerning symptoms ongoing. Then you can run a fit report every week using the Arden's tool to kind of make sure that the fits have been returned and then the results acted on appropriately. And then making sure that you're coding correctly if a fit is declined or not indicated. So here we've got kind of some useful codes to ensure that you will get your payment for the IAF funding if you can't do a fit for any reason. So there is a decline code there. We know that there are issues where sometimes, you know, fit kits get lost, and actually you may, you know, with concerning symptoms, be wanting to refer a patient on that lower GI pathway but not have the fit result. And we've brought that up with NHS England just to look at developing a further code, you know, to make sure that we can cover those kind of bases. But these are the main ones that would be really useful just to have at your fingertips and make sure that that's all in the Arden system. But if you're using the template, they'll be there as well. There was an issue with matching the fit result to SNOMED codes. I think most people have sorted this, you know, because the CAN 01 target was there last year. But just if anyone is having any problems, there is a useful guide about how to fix that. We've got a admin poster that you can print off, laminate and put up in reception areas. And really this is just to make sure that we're giving out the right kits. So making sure that the reception teams are aware of which bottles and what to do, and how to communicate with patients around this. I'd also say just making sure that everyone's got adequate supplies. I know it pops up every now and then that people aren't getting their full orders, and it may be that you just need to revisit how many you're requesting on your regular supply list, just because obviously we are increasingly using it, and just needing to make sure that we've got adequate supplies that we can hand out, because it's a bit of a nightmare when you're having to keep lists of patients to then contact when those fit kits come back in. So this is the AccuRx template, which is really, really useful. So you can, it's a one that everyone should have access to. So you just type in fit and it will come up with that fit sample reminder. And once you click on it, you can edit, you know, the information that's in there, and also the timeframes when it's sent out if you wish, but it will send 2 text messages just to remind the patient the importance of sending over of completing their fit and bringing it back in. So once we've got that result, it's obviously coming through the pathology list link, and then you can code it into the Ardens template. I think one of the really important things is just looking at that process for who's monitoring the results. So and this is especially important for those fit less than 10 results, and just thinking about the systems that you've got in place in practice in terms of, locums, absences, and how people are covering it. And I think that's the bit where it's really useful if you've put some clinical information so that comes back through with the report, and you can think about, even if that result is less than 10, what action you will need to be taking and correlating that with the clinical history and the bloods. So as we've discussed, those fit greater than 10s need that suspected cancer referral, and we've just put in the agreed standardised comment that will come back with that into your path links. So obviously you're going to be contacting the patient, making that referral, ensuring that you've got the fit and the blood results attached. And then there's a useful AccuRx that you can send to patients with a link to the urgent suspected cancer patient information leaflet, just to remind them about the importance of attending their appointment. And on our website, we've got all the contact details by trust for patients to directly follow up with the trust if they haven't heard about their appointment. So it's worth potentially just making your own SMS template just to send out to patients so that they can ensure that they know who to contact. And we do have that leaflet as well, translated into multiple languages. So I think the real kind of complex bit for primary care is those fit less than 10, as we've discussed. Again, we've got that standardised report which will come through, which is very wordy, but designed to kind of give you as much information so that you can remember this guidance when you're actually assessing the patient in front of you. And I think we just need to kind of get into the mindset that actually a fit is a little bit like a CA125 or a PSA result, and potentially you'd still be reviewing that patient if they had ongoing symptoms. So generally, if you've requested it because you're concerned about something, even if it's less than 10, you'll be wanting to follow them up and correlate whether they've got any ongoing symptoms, especially kind of then looking at the bloods with the iron deficiency anemia side and wondering whether they need still a suspected cancer referral if they've got those red flag symptoms. And then very much it's thinking about those alternative pathways. So actually, are they potentially more gynae or urology? Or if you've got a non-specific symptoms clinic, then would you be referring in there if you're still worried about a cancer, but not necessarily a colorectal one, if that fit is less than 10? Otherwise, you've obviously got the urgent lower GI route or advice and guidance as well. And then just making sure that we're safety netting those. So, even if you think, okay, well, everything's settled, just the kind of wording that we give back to patients around that to kind of represent any red flag symptoms. So I wanted to just touch on the changes to the IAF funding. So this is new since April. And so from a primary care perspective, you will only get paid for that activity if you're doing the fit 21 days before the referral is sent, and that threshold is lower now, so it's 65%. So this is where actually those Ardens templates and all of those resources are really, really useful. So just making sure that you've kind of used those codes that we discussed, the provision of the fit kit, the result being received, the fast track referral, or if that fit's declined. And as I say, Ardens have got some templates and searches that you can set up, and you may want to just look at your systems in practice as to who can help to monitor those and bring to the attention if fits haven't been done. And as I've said before, just kind of making sure those clinical details are on the form so you can correlate things. I appreciate from a primary care perspective, I think it is a bit of a kind of new thing to get our heads around, and actually I think people are nervous about the kind of multiple contacts that you may have with patients in view of this new guidance, and I think it's just about making sure that everyone's kind of aware of the changes and why they're there, so kind of cascading that through to clinicians if they're not on the call, so that they're aware. We've discussed kind of the issues around repeat testing, and obviously stock supplies being up to what you're using in practice. The safety netting aspect, it is, I think Ardens make it a lot more useful, but it is kind of quite heavy still on staff resources, but just thinking about how as a practice it best works for you and how you want to make sure that you can safety net these patients, but just having those robust kind of fail-safe systems in place. And obviously we do need to kind of put onus on the patient as well, so that initial communication with them about why we're doing this test and them following up on it as well. We've discussed a little bit about age. I know that occasionally there are some very young patients who are being requested to do a FIT and then being referred in potentially, and actually really considering whether it's appropriate in those very young patients. And I know it's been touched upon as well in terms of the frailty aspect. And obviously sometimes it's useful to have a diagnosis, and it may be useful, you know, to understand whether there is something potentially colorectal, but actually whether people are fit to then proceed for further investigation or treatment, and how far you might take that. So having those quite difficult conversations with families about, you know, how best to use these tests in primary care. So just before we kind of move into the questions that have come in, just to kind of really emphasize those take-home messages. So, you know, there are different thresholds for the symptomatic and the screening fit. And so not to kind of falsely reassure patients if they've had a screening fit that they wouldn't need to have a retest in primary care or contact to find out their fit result from the bowel hub. Making sure that actually all those patients that we are referring on a suspected cancer pathway to colorectal have a fit, and that's even in the presence of rectal bleeding, as we discussed earlier. And that only exemption is in the presence of an anorectal mass or ulceration, but actually if you can request that at the time of referral, it really helps on the triage aspect going forward as well. So that IAF target has changed, so the FIT can be completed up to 21 days before that referral is made. Afterwards, it won't be funded. So really, really important from our perspective to make sure we've got systems in place to ensure that is done. And then just thinking about those systems that you've got in place to manage those requests and results, and using those ARDENs and AccuRx tools for that. Advice and guidance is there if you need it, but just remember that no referral should be rejected if a FIT is unachievable or unavailable, or if it is less than 10, you know, and you've given those kind of reasons behind it. And actually having that clinical information is really, really useful for secondary care. So please do include as much as possible with that. So I'm going to hand over to Jo. Is there anything that's come through in the chat that we can address?
No, I think they've probably been answered as they've gone along. So there was a question on repeat FIT testing interval, and I think Sally put something in the chat. And I think the context behind that perhaps is when, you know, somebody comes back after a period of time, when do you do another FIT? And I think that's a bit of a clinical conundrum that we all face. And I don't know whether Neil or Phil have any thoughts on that in terms of, you know, if somebody represents what is acceptable.
So I think it's very difficult. Agreed. I guess it really comes down to the symptoms, and I mean, because if symptoms are recurrent and difficult enough, then you might make a referral anyway. I don't think it's a problem I don't think it's an issue that we'll have to dwell on for very long, because I think that the repeat FIT message is going to be addressed, and as Sally said, evidence is emerging. But I think it's important, particularly. I think that the area that I think is really one that we probably haven't discussed is should you be doing another FIT test if somebody's recently had a colonoscopy? And of course, you know, that sort of puts us into the category where, you know, we know that once you've had a colonoscopy within the last 3 years, then your risk of bowel cancer is really pretty low anyway. So another FIT test is not going to contribute very much to it. But I don't think we've got the answers to the repeat FIT test, but I think it's probably going to be, you know, within the year, perhaps something like that. But that's just a guess. But it will emerge.
Okay, there's a couple of questions in the chat here. I'll just start. I've lost one. I think Anuja has written, does that mean if I send a 2-week rule referral due to a mass today, so this is an anorectal mass, I'm assuming, and the FIT test, which I added on the day to do to the 2-week rule referral, will not be paid? Yes, because it's not in the IIF funding for those particular indications, but obviously you will get paid for all the other FIT tests. Am I correct, Kat? Have I got that understanding right?
I think it's more that it's not going to be in your target, so your threshold isn't going to be affected. If you're making sure that you're using the right code to say it's not indicated, then you're not going to be penalised. So I wouldn't look at it necessarily as kind of a payment per fit. It's more that it's making sure that the threshold is reached for those fits that you do. They're on the right cohort, and you don't want to delay the referral, but actually it's in the patient's best interest that you still request that fit and get them to return it, so that when they're in secondary care they can use that result to inform decision making.
And all the codes for those are on the website, a link we've put to in the chat as well. Thank you. There's a question, I think, for Neil here. Esther Walker, how long is the current waiting time for an urgent referral in Sussex as opposed to a cancer pathway lower GI referral? I'm not sure I know the answer to that.
I'm not sure I know the exact answer, but what we've got now is a happy situation whereby the faster diagnosis teams have taken on responsibility for 2-week rule referrals for FIT, and they're processing up to sort of 400 or 500 a month. Which means that the waiting times for non-urgent referral to see the clinicians are coming down. It might not be completed yet, but obviously the FDS teams are going to be picking up more and more and more, which releases the clinical consultants to do that. I can't tell you an exact number, but it's getting better, and it will be different on each site.
Thanks, Neil. There's a couple of other questions. So there's one here from Paul McDermott. Should relatives of patients who have had colorectal carcinoma be monitored, and if so, how often?
So can I pick that up, Jo?
Yes, please do.
So that it depends a bit on the number of relatives. If you're in a family history pedigree, which is genetically proven, for instance, Lynch or FAP, then you will be monitored anyway by the trust. If you've got a lesser family history, the consideration is that those people are not at a higher risk of cancer than the general background risk, and that's what the screening program's for. So we have a screening program to pick up average risk, and if you don't fall into a high risk genetic group, then you will be looked after very ably by the screening program. So you should definitely encourage those people to do the bowel cancer screening program.
Sally, did you want to come in there?
Yeah, I was just going to say, and Neil will know more about this than I do, but there is the BSG published some guidance on family history, and I have sent this out to GPs in the past if they've questioned it. So is that up to date enough still, Neil? Is that something we could?
Yes, Jess. I mean,
yeah,
I think it's quite complicated, but essentially anybody that is in a dominant pedigree will be already looked after, and as you know, the screening program is picking up the Lynch syndromes. But people who have an average risk, it's enough to know that the screening program is there for them.
Yeah, I guess that we get quite a lot. I get quite a lot of queries about that through the screening and the the primary care network. So yeah, hopefully I'm doing the right thing sending out that paper.
It's always useful to have. Thanks, Sally. And Phil, I think you wanted to come in.
Just following what Neil said about frequency of referral, I think those patients who are referred within, say, a year of previous referral investigations, I think the important thing that we want to know, and that certainly the triage nurses look at this. They look at how successful the previous colonoscopy has been as to whether it needs to be redone. But broadly speaking, if you do refer patients on very frequently, then you may well find that those patients are triaged onto another pathway, having spoken to them first. So referring them on the urgent care doesn't mean that they stay on that pathway. We may make decisions, having talked to them, have the advantage of getting hold of the tests that you may not be able to get, and other clinic letters, it may be that we would refer them or take them off the urgent care, or even direct them into another pathway.
Thanks. I'm just going to take one more question, which I think is quite a pertinent question, and it's not a silly question, Olivia. You mentioned that the only exceptions for completing a FIT are an anorectal mass or ulceration. This may be a silly question. Is it still required if there's visible blood in the stools without obvious cause on examination? The answer is most definitely yes. Even in the presence of visible blood, it's still worth doing, because the threshold, like Neil and Phil were saying, is the thing that will lead to the right test, essentially. So do it anyway. I think that's it.
On that with Sally.
Sorry.
Yeah, Sally,
Oh.
do you want to come in? I was just going to say about advice about how to take that sample.
Oh yeah, where to do it.
So I was going to say that I'll be really quick so I can see it's 2 o'clock. That the evidence, a lot of evidence has been generated quite recently in patients with rectal bleeding and FIT, and it does demonstrate pretty much the same sensitivity at a 10 threshold, whether you have rectal bleeding or not. And it's thought to be because if patients have visible rectal bleeding, if they are and a known history of hemorrhoids, they're advised to take the sample to put the probe in a little bit deeper. So the rectal bleeding sort of that is very visible might be because of hemorrhoids. It might not be, but that's the advice. So yes, it's deemed a very good, if it's negative and patients have visible rectal bleeding, it's still considered a good test as a rule out test.
Thank
That
you,
makes sense.
Sally. No, that's really, really useful, I think, for us to understand. If you have any further questions, please do feel free to email us. As I say, we're going to compile questions that we had from the Sussex webinar last week as well, and then circulate those out. But hopefully you have found this incredibly helpful in terms of demystifying FIT and how to use it in primary care. So if you do have any questions, do get in touch, but we will send out all of the recording, slides and resources out to you so that you have those going forward. But thank you very much to our wonderful speakers for joining us today and imparting all of that information, and thank you very much to you all for taking your precious time to come on a Tuesday lunchtime, and we look forward to seeing you at educational events going forward. All right, thanks very much everybody. Have a good afternoon. Bye for now.
Bye.